Welcome to this presentation on hyperglycemia, diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic state. I'd like to start by acknowledging with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. We thank them for their stewardship of these beautiful lands from time immemorial. So we're going to talk today about defining hyperglycemia, DKA, and HHS. Look at the signs and symptoms and differentiate between ketone bodies and beta-hydroxybutyrates. We'll review the rationale for treatment of DKA and HHS and provide instructions on how to move from an IV insulin infusion to subcutaneous injections or a person's own insulin pump once DKA or HHS is resolved. I'm going to outline how to counsel a person with diabetes on preventing future hyperglycemic episodes. So we'll start with the definition of hyperglycemia. It is typically a glucose that is greater than 10, double digits, and a sustained glucose greater than 14 millimoles per liter requires treatment. So especially for those with type 1 diabetes, they would really need to start looking at their ketone bodies when the glucose levels are rising over 14 and they're not able to get them down with extra insulin. All of the signs and symptoms associated with hyperglycemia are as a result of glucose having an osmotic effect. So when you have osmosis, it will pull the fluid and some electrolytes into the bloodstream where the high glucose is located, and that leaves a person dehydrated and thirsty, as well as electrolyte imbalances. So here we have polydipsia, they're very thirsty, they have dry mouth or skin, they're polyuric, so they are having to void an awful lot, much more than usual. They're lethargic because the glucose is sitting in the bloodstream and it's not in the cells where it needs to be in order to feed that cell. They're hungry or nauseated. They have a headache, and that's all that fluid shifting and electrolyte imbalance going on. They can be emotionally stressed because of that extra fluid in there, and as you know, if someone gets into alcohol, they get dehydrated, and headaches are affiliated a lot with dehydration. They can have stomach cramps because of the electrolyte imbalance, and they can have a fruity smelling breath like acetone or alcohol because it's the body's way of trying to get rid of these toxins or these ketones. So what causes a person to be hyperglycemic? Well, they could have missed their dose of insulin. They could not have taken enough insulin for the amount of carbohydrate they'd eaten, so either they miscalculated or they just chose to give their normal dose and ate extra carbs in that meal or snack. And they might choose higher carbohydrate foods, especially the high glycemic ones that dissolve very quickly as glucose, as opposed to the lower glycemic indexes, which release the glucose over a longer period of time, which has less impact on the glucose levels in the blood. They could do nothing different apart from being ill. So illness will cause release of cortisol, the stress hormone, and they could be doing everything perfectly and be ill, and the glucose levels will go up. Again, with stress, they didn't do anything different, but they're experiencing some stress in their life, and those cortisol levels go up. They could be prescribed other medications such as steroids or antipsychotic medications, which have an impact on glucose levels because they increase insulin resistance, which means the amount of insulin they give normally is now meeting resistance and won't finish the job of bringing the glucose into the cell to feed the cell and leaving it in the bloodstream now. Cushing's syndrome is a disease where there is extra cortisol released in the system, so same premise. All of these things, apart from food or diet or activity, can cause the glucose levels to go up. So what do? Definitely we're into sugar-free liquids. We're not into hypoglycemic treatment where we're giving them pop or juice. We want them to drink sugar-free liquids, whether that is water or Mio or Crystal Light or something that hasn't got a lot of sugar in it. We want to replace and replenish the fluids that are in the that are missing from the extracellular fluid there. Remember, the person's dehydrated, so they are going to have a need for extra fluid. We'd like them to take extra insulin and check their glucoses more frequently if they're just in a hyperglycemic state. So this is, sugars greater than 10, not in DKA, not in HHS. That usually requires some deeper intervention. And if they have type 1 diabetes, they should be checking their ketone levels if the glucose is sustained over 14 and not able to come down with extra insulin. So this lovely complicated slide of pathophysiology of DKA, the way I explain this is you've got really easy buckets of glucose that will deliver the glycogen, which comes out as glucose in the bloodstream, directly into the bloodstream when you need it. So the liver is like our gas tank for extra fuel to put in extra sugar for us when we need it in times of fasting. So if the liver has delivered all of its sugar directly into the bloodstream, and now the cells are still not receiving that glucose because there's not enough insulin to carry the glucose from the bloodstream into the cell to feed the cell, that means the body has to go into its harder to reach gas tanks, and that would be in the muscles, kidneys, and adipose tissue. And the breakdown of the glucose from these areas spins off some toxins called ketones and beta-hydroxybutyrates. So they are causing the catabolic breakdown. In order to get that out, spins off some toxins. And this is where the diabetic ketoacidosis can come in. Now let's talk about the difference between ketones and beta-hydroxybutyrates. So everybody who is watching this who doesn't have diabetes can put themselves into ketosis. All they do is drastically reduce the amount of carbohydrates, and we will put ourselves into ketosis. And this is why people on very reduced carbohydrate diets like Atkins diet or the keto diet, they will actually have a fruity smelling breath because the body is in ketosis trying to break down the glucose from the fat stores, which is what their aim is to try to lose weight. But not everybody in this room or watching without diabetes can have BHBs or beta-hydroxybutyrates. They're more specific to identify ketosis in people with diabetes. The difference is, though, that you can't test beta-hydroxybutyrates at home. And so for someone with diabetes, the only thing they have are ketone testing capacities with blood ketone meters that are special to that, and strips that go along with it. They can't test a beta-hydroxybutyrate at home. But if they do end up in hospital, then we really want to test them for beta-hydroxybutyrates because we have the capacity to do that in hospital. And if you've got someone on a severely carbohydrate-reduced diet who also has diabetes, they may have ketone bodies, but they might not be in diabetic ketoacidosis because it's a result of the dietary restrictions of carbs. So in hospital, we'd like to test BHBs. And anything over the 0.42 is actually considered a higher beta-hydroxybutyrate. But on the previous slide, we showed that anything over 3 is starting to get into diagnostic of DKA. And when we get into over 5.9, then we're looking at severe DKA. And people will come in sometimes with beta-hydroxybutyrates of 12, which is very high, and we definitely want to treat. So here's a chart that shows the diagnostic criteria for DKA, and then I'll go over the one to the right for HHS. You can see here that serum glucose over 14 could indicate DKA in either a mild, moderate, or severe state. Some people are very sensitive to DKA, and so 15 puts them into DKA. Other people can get up to 50, 60, 70 before they're in severe DKA. The arterial pH, you will notice, will go down, and that's because they are acidotic. And so the more acidotic they are when the pH is less than 7, then they're into severe DKA. The bicarbonate levels will also start to drop. There will be ketones in the urine as well as the serum in DKA. It's in the name, diabetic ketoacidosis. And the anion gap is going to start getting greater as the severity of DKA increases. And you can see as well that from the mild to severe, their mental status is going to deteriorate and they could possibly go into stupor or a coma as they get into severe DKA. So in HHS, the plasma glucose can be quite high. And I put greater than 25, but I've seen as high as 90, 100, 108.2 is actually the highest I've ever seen. And that was HHS. So they can have quite remarkably high glucose levels without decompensating in HHS. It's typically reserved for people with type 2 diabetes, this HHS state. You'll see the arterial pH and serum bicarbs are normal or near normal. There won't be many ketones in there at all. Anion gap will be fine, but their mental status can also deteriorate as the more severe it gets. But it's the osmolality that is going to be the diagnostic criteria. So if their osmolality is greater than 320, then they are definitely in a hyperosmolar hyperglycemic state. And here's another slide that shows that both DKA and HHS can have hyperglycemia, but they don't both have metabolic acidosis. DKA is typically showing metabolic acidosis, whereas HHS is showing the high serum osmolality. And then you'll see as well that in DKA they'll be ketotic, but there'll be significant absence of ketosis in HHS. And really, we're mostly see DKA in people with type 1 diabetes, but I'm sure you've heard of the SGLT2 inhibitors like dapagliflozin, canagliflozin, and empagliflozin, which can cause DKA with a relatively normal glucose, like maybe 12 to 14, 15, and they can tip into DKA, and that can happen in type 2 diabetes. And it's usually as a result of a person being ill and not taking a lot of fluid in, and the glucose levels don't rise, but the ketone levels can. Whereas in HHS, typically you're going to see that in type 2 diabetes, but there are rare occasions it will happen in type 1. So what's our rationale for treatment? First thing we want to do, replace those fluids. So they're dehydrated, we need to replace the fluids, and that's why they're getting sometimes a liter an hour, and it depends on their fluid state as to what the prescriber will order. We want to provide insulin therapy in order to try to get those electrolytes back where they belong, because right now they're sitting in the bloodstream, they're getting voided out, so the potassium and sodium levels are going down, and the cell is not getting fed because, as we know, most cells are running on the sodium-potassium pump. Notice I haven't really mentioned too much about insulin here, that we're talking about fluid first and getting that dehydration sorted out. Then we're adding the insulin, which actually happens usually an hour or two after the initial fluid replacement. And that is, we're wanting to lower those glucose levels slowly. We do not want to drop their sugar levels quickly, because as you know, you'll get an autonomic response into the hypoglycemic range if we drop them off the cliff. From a sugar of 30 down to 10, they're going to feel pretty rotten. So we're trying to lower those glucose levels slowly. So the treatment orders for DKA and HHS will vary slightly between organizations, so please follow your own organization's instructions on the treatment, but the goal is to address the electrolyte imbalance and dehydration while reducing the glucose levels slowly. So now what are the treatment options for hyperglycemia without high ketones or beta-hydroxybutyrate, so HHS? So we want to start giving, they might put them on an insulin drip initially in order for them to drop the glucose levels, but then we do really want to get them into some rapid-acting analogs because they're the best way to reduce glucose levels. They peak in 60 to 90 minutes after the injection. So really within an hour to an hour and a half, you're going to see some traction on it, and the sugars should be starting to come down slowly. The fast-acting insulins like R or Toronto, they take longer to release. They're not peaking for 2 to 4 hours. So they're not recommended to reduce glucose in a hyperglycemic situation that you want to bring them down a little more fast than 2 to 4 hours from now. And that's really important, that if a prescriber asks you to give Humulin R and then contact them an hour later with a repeat glucose, you're going to want to push that off or discuss with them waiting at least 2 hours, because the effect of the R or Toronto is not going to be shown for at least 2 to 4 hours. So I just this will be in the insulin module as well, but I just wanted to show you this insulin action graph because it's so visible and visual. And you can see here that the rapid acting analogs are the ones that really get in quickly, peak quickly, but they're also gone quickly. They're gone in about 4 or 5 hours. Whereas the Humulin R is taking a little bit longer to peak, and it's a little longer to get out. You would never want to treat with NPH or glargine, any of these Tresiba, Toujeo, or a weekly. Those are long-acting insulins. They will take far too long for the glucose to come down. Now, when you want to change them from the insulin IV drip infusion to the subcutaneous injection or their own personal insulin pump, it's important to know that insulin given intravenously is absorbed much more quickly than subcutaneously. And of note, if you gave Admelog subcutaneously, it peaks in 2 to 4 hours. It's about 30 minutes for it to start working. But if you gave Humulin R, it's not going to peak for 2 to 4 hours. When you give either of those in the IV, they're going to act much quicker and the same, because they don't have to go through the subcu tissue in order to have their different formulation absorbed at a different rate in the subcu tissue. So that's why we can put either a rapid acting or a fast acting insulin in an IV infusion, because they'll act the same. It's just that rapid actings cost more. So subcutaneous injections and insulin pumps that are person's personal pump, they both deliver insulin via subcutaneous tissue. So there's going to be more of a delay in absorption, which means you have to have a crossover period. It allows the subcu insulin to start absorbing before you turn off the IV infusion. And if you stop that drip too early, the patient's left with no insulin on board and could rebound into hyperglycemia. So absolutely there needs to be a crossover period. And you can see here, if the prescriber orders, let's say they want their basal insulin to start, you have to wait at least 90 minutes before you stop that IV infusion, before the long-acting insulin could pick it up. Typically they're going to start giving a rapid-acting insulin and say wait 30 minutes before you turn off the IV infusion. So how do we prevent hyperglycemia and talk to the patient about this? We want to examine the insulin and the insulin regimen as well as the anti-hyperglycemic agent regimen if they happen to be on that. And if there's a mismatch or things have changed, then we need to make some adjustments for them. They need to bring extra rapid-acting insulin with them if they're away from home for a lot of hours. And this is very important in someone with an insulin pump, because if they're on a pump and that pump kinks, the tubing kinks or falls out, very rarely do we have pump failures, then they need to give some rapid-acting insulin quickly, or else they will go into DKA much more quickly than someone who's got a basal insulin on board. So they really should be bringing some rapid-acting insulin with them, or at least a syringe to be able to pull that rapid-acting insulin out of the pump reservoir and inject it into them. They need to take extra insulin for high carbohydrate meals, so counseling them as to how they would do that. Monitor their carbohydrate intake, so maybe they overdid it and they need to back off a little bit when they're in this high glucose state. They should wear something to advise others of the risk of hyperglycemia, so a medic alert, jewelry, or mentioned before in a different module, a forearm tattoo. Some people will have type 1 diabetes written on their forearm so paramedics could see, and carry a glucose meter, or wearing a CGM, a continuous glucose monitor, has a wonderful ability to let them know if their sugars are going high. A glucose meter with ketone test strips is all we have in Canada right now, but there are CGM, CKM, continuous ketone monitor combinations that are being created right now. So the key messages are that DKA is diagnosed with excessive ketones or beta-hydroxybutyrates and is more common in type 1 diabetes or those on SGLT2 inhibitors with type 2 diabetes in an ill state if they don't stop the SGLT2 inhibitor when they're not taking good fluid intake. HHS is diagnosed with high serum osmolality, but it doesn't usually involve excessive ketones or BHBs, and it's more common in type 2 diabetes. BHBs are a more specific indicator of DKA than ketones when admitted to hospital, but people with diabetes only have access to blood and urine ketone testing in the home setting. And of note, urine testing for ketones or blood is 3 hours old. So it takes that long for that blood result to filter through the kidneys and come out onto the test strip. So they're really not that accurate. It's also imperative to leave the insulin IV infusion on for a period of 30 to 90 minutes, depending on the type of sub-Q insulin given when crossing over from an IV infusion to a subcutaneous injection or their own personal insulin pump. And you always want to examine the cause of the hyperglycemia, DKA, or HHS to prevent further episodes.